Audible and visible. Can you all give me a quick thumbs up if my audio video is fine? Let me just check if you all can hear me and if my audio video is all fine. Just give me a second. Yes, amazing. So welcome all of you in this class of dermatology, the rapid fire revision for the FMGE students. So we'll be starting this session till the others join. Let us quickly go through the regulars, everyone. So get ready for the today's class. I'm Dr. Chesta Aggarwal, your NEET PG educator on the best online platform, that is Unacademy. Now the prices of the Unacademy subscriptions are hiking very soon. So if anybody interested, I request them to please use my subscription code CHESTA10. Please go ahead and get your subscription. We have a 6+2 offer, that if you buy a 6-month subscription, the 2-month becomes free. For this also you need a code, and the code is CHESTA10. We are starting with new batches, that is Target NEET PG. There are many new batches which are getting started. We have all amazing educators, they are listed here. So I would be requesting all of you to kindly go ahead and get your subscription. We have free test calendar for this month. You can use my code CHESTA10 to get yourself enrolled. Now we have also launched the auto daily practice papers. We have Unacademy Lite subscription for the NEET PG students. You can use my code CHESTA10 and get your subscription. We have also launched a UPSC CMS batch, which will give you an access to UPSC batch in just rupees 2475 using this code. We have MBBS Prof 1 batches starting with just rupees 4975 using this code. We have free live classes on the app known as special classes. Then we have plus subscriptions which give you an access to a lot of classes. Iconic give you an access to Unacademy and Prep Ladder. And we have NEET PG subscription which give you an access to Plus, Iconic, Lite, MBBS and UPSC CMS. I request all of you to kindly get yourself enrolled. You need a code, and the code is CHESTA10. Starting with the first question of the today's class. So a female patient presented with active genital wart with history of recurrence, but her husband doesn't have it. So one of the partner have the lesion and another patient is negative or having no lesions. Now the question is how to prevent the spread of the infection from the infected patient to the non-infected patient. What prophylactic measures can be given for preventing the spread? This is a very interesting question because there is no prophylactic methods or therapies which can be given to the patient to prevent the spread. What can be done? You can simply ask the patient to avoid involving in the sexual intercourse with the active patient. That is the only way which can prevent the spread of infection from the infected patient to the non-infected patients. There is no prophylactic antivirals, there is no prophylactic drugs, or there is no active antiviral drugs for the lesions. Next question. Anyone? Anjali, Rishi, Dev, Nikhil. What is the answer here? Very nice, all of you. Very well done. The correct answer of this question is Chidak-Higashi syndrome. Now, in this patient, you have lack of melanin in the epidermis with history of recurrent infections and involvement of eye with decreased pigmentation. I hope you can see all these features. Am I audible and visible to all of you? Very nice. Chidak-Higashi syndrome is a variant of oculocutaneous albinism. And you have an associated List gene defect which is responsible for recurrent infection in them. So the correct answer of this question is option number 2. Clear? Next question. I don't know why all the answers have raised upward. Angel, Kostu, Nikhil. What is the answer for this question? A 13-year-old boy with a history of burning sensation on the exposure to sun. On examination, he has a grade 1 malnutrition and dull brown pigmentation with areas of speckled hypopigmentation telangiectasias over the exposed areas since 4 months of age. What will be your diagnosis? Rothman-Thompson syndrome, xeroderma pigmentosa, cocaine syndrome, or Bloom syndrome? What will be the correct answer here? 13-year-old boy with a history of burning sensation on the exposure to sun. Grade 1 malnutrition, dull brown pigmentation with areas of speckled hypopigmentation and telangiectasias over the exposed part since 4 months of age. What will be the diagnosis? Please remember, the correct answer of this question is Rothman-Thompson. Rothman-Thompson is an example of poikilodermatous syndrome. Poikilodermatous syndromes, they belong to a group where there is telangiectasia, speckled pigmentation, and there is atrophy of the skin. So whenever you see this classical triad, you have to classify the patient into a very classical feature, that is Rothman-Thompson. This is not a feature of nucleotide excision repair. Please remember, speckled hypopigmentation, telangiectasia and atrophy with associated features of retarded growth, very classical of Rothman-Thompson. The next question is on your screen. It's a little difficult one, but it's a PYQ. We got a very similar question in a few exams few years back. John, in these individuals you have physical and mental retardation, and that physical retardation is actually seen in a form of malnutrition. Okay. Anyone can tell me the answer? Very nice. This is a very classical example of carotenemia. The question is, a 43-year-old gentleman, history of bronchial asthma and recently diagnosed distal gastric leiomyomas. The changes which he started noticing is a yellowish orange discoloration of the body, mainly hands and feet. There is no feature suggestive of obstructive liver disease like pruritus, darkening of urine, pale stool. The patient is even anicteric. LFT, TSH, coagulation studies are all within normal limit. So no feature suggesting of obstructive liver disease was found. But when we take a history, patient give a history of consuming papaya and mangoes, which are rich in beta carotene. So it's a very classical example of beta carotenemias. Clear? Next. Please tell me the answer here. Please tell me the correct answer here. Anyone can tell me the answer? Very nice. John, Kriti, Anjali. A 25-year-old man who developed small itchy wheals after physical exertion, walking in the sun, eating hot spicy food, and when he was angry, what is the most likely diagnosis? So what happens when patient do all these things? Walking in the sun, eating hot spicy food, when he is angry, what happens when the patient has physical exertion? In all these conditions, there is increase in the core body temperature. And when the core body temperature increases, what happens? There is a release of acetylcholine, and this will give rise to cholinergic urticaria. So the correct answer of this question is cholinergic urticaria, which presents with small microvillus. It presents with small microvillus. Next question is on your screen. Uncontrolled diabetes mellitus and hypertension. Both of this are the strict contraindications of providing steroids in these patients. So the other treatment modality which can be given in these patients of airborne contact dermatitis is azathioprine. Cyclosporin can also cause renal hypertension, while thalidomide is not an effective drug for airborne contact dermatitis. So please remember all these features, they are very, very important for your exam. Clear? What is the answer here? Anyone can tell me the correct answer for this particular question? A 5-day after an unprotected homosexual intercourse, a 27-year-old male presents with complaints of burning micturition. There is no frank pus, but on milking the urethra, some discharge was collected. Gram stain shows diplococci. What is the diagnosis? Nice. The answer to this question is gonococcal urethritis. Please remember, we have two causes for urethritis. One is gonococcal urethritis, which is because of Neisseria gonorrhea, and non-gonococcal urethritis, which is mainly because of chlamydia. Now, gonococcal urethritis will present with a short incubation period, and on doing the gram stain, you will see diplococci. While non-gonococcal urethritis will have an incubation period of more than equals to 2 weeks, and there will be no organisms which is visible on the routine microscopy or culture. For demonstrating, you need to do a nucleic acid amplification test, and the incubation period should be longer. The next question is on your screen, a very easy and a simple one. Anybody can tell me the answer? Very nice. The answer to this question is rosacea. Now, what are the points in favor of rosacea? So let us mark it one by one. A middle-aged female with a 2-year history. The lesions are erythematous and papulopustular. The lesions are erythematous and papulopustular, present mainly on the convexity of the face. Present mainly on the convexity of the face. She reports that whenever she goes out for shopping or gets angry, she develops increased erythema over the face. On examination, there is a background of telangiectasias. So presence of aggravating features, presence of lesions on the convexity of face, all these points towards the diagnosis of rosacea. Now why it is not a patient of acne? Because in acne, please remember, you should have presence of comedone. The patient will be an adolescent female or male, and there will be no aggravating features like what is given here. In SLE again, there will be no aggravating factor, and instead of that you have a fixed lesion. No aggravating factor, and instead you will have a fixed lesion. Clear? So these are some of the differences which you should know. The next question. A young female presented to emergency department with complaints of severe abdominal pain, bloody vomiting, upper GI endoscopy was done, gastric carcinomas was diagnosed, and the patient was started on chemotherapy for the same. 2 weeks later, she reports increased hair loss for which a dermatology reference was made, and on doing trichoscopy, the diagnosis was also done. What is the answer here? Very nice. If somebody starts the hair fall after starting the chemotherapy, this is a very classical feature of anagen effluvium. Please remember, this year in NEET PG 2022, we got a question on telogen effluvium, which is secondary to the illness, and the hair fall start after a lag period of 3 to 4 months. But in anagen effluvium, you should have a chemotherapeutic agent which affects the rapidly growing hair, and the lag period is shorter compared to that of telogen effluvium. Next question. A primigravida presented in the late second trimester with itchy erythematous papule plaque that progress to tense vesiculobulous lesions over the lower abdomen involving the periumbilical area. Direct fluorescence shows presence of linear C3 and IgG. Which of the following statement about this skin disease is not true? Anyone can tell me the answer? Anybody can tell me the answer for this? A primigravida presented in the late second trimester with itchy erythematous papules and plaque that progressed to tense vesiculobulous lesion over the lower abdomen involving the periumbilical area. Direct immunofluorescence shows presence of linear C3 and IgG. Which of the following is the correct answer? Which of the following is the correct answer? Very nice. The correct answer of this question is, anyone? Whenever you have C3 and IgG and presence of lesion in a primigravida, the diagnosis is of pemphigoid gestationalis. Pemphigoid gestationalis. It is nothing but bullous pemphigoid of pregnancy. You may see the lesions in newborn if there is transplacental transfer of antibodies. The estrogen is a precipitating feature, and that is why pemphigoid gestationalis is more frequent in second and third trimester of pregnancy. It may recur in further pregnancies, but please remember it has nothing to do with herpes virus. Now why they have made this option? Because because there is a misnomer, or this disease is also known as herpes gestationalis. There is one more name for this condition known as herpes gestationalis. But please remember, it is a misnomer. Herpes gestationalis do not occur in these individuals, or herpes genitalis is not an infective condition. It is just another name for bullous pemphigoid of pregnancy. Is this clear to all of you? Can I get a quick thumbs up from all my dear students if this is clear? All of you? Very nice. Next question. What is the correct answer? A 2-year-old man had multiple small hypopigmented macules on the upper chest, back. Sorry, it's not 2 years, it is a 21 year. The one is missing here. The one is missing here. Anyone can tell me? A 21-year-old man had multiple small hypopigmented macule on the upper chest and back for the last 3 months. What will be the correct answer here? What will be the correct answer here? Very nice. This is a very classical description of pityriasis versicolor. Now what are the points which favors? You have small hypopigmented macules on the upper chest and back. They are mainly around the follicles, perifollicular lesions. They add coalesce to form large sheath, and the surface of the molecule shows fine scales over them. Which of the following is the most appropriate bed test? So if it is pityriasis versicolor, the most appropriate bed test is KOH mount. And in KOH mount, what will you see? In KOH mount, you will see a very classical spaghetti and meatball appearance. Spaghetti and meatball appearance. If this is clear, I request a quick thumbs up from all my dear students. If this is clear, I request a quick thumbs up from all my dear students. Next. Harshita, Faraz, Anjali, Kirti, John. Very nice. The next question is on your screen. Now, a 22-year-old female who presented with multiple asymptomatic hypopigmented macule all over her back since past 6 months. She was started with topical emollient, topical steroids by a local doctor, but there was no response. On Wood's lamp examination, there is a perifollicular orangish red fluorescence. What can be the diagnosis? Very nice. Now the clue to the diagnosis here is the Wood's lamp finding, which is perifollicular orangish red fluorescence. Please remember, in vitiligo you have ivory white. In vitiligo you have ivory white pigmentation. In pityriasis versicolor you have yellow fluorescence, not pigmentation, yellow fluorescence and ivory white fluorescence. In post-inflammatory hypopigmentation there is no fluorescence, or if at all it is present, it is ivory white. But in progressive macular hypomelanosis, they have a very, very characteristic orangish red fluorescence surrounding the hair. Orangish red fluorescence surrounding the hair. The next question is on your computer screen. The next question is on your computer screen. Please give me a correct answer. If you read, there is a 53-year-old female with lesions on the skin as well as lesions on the muscles, the muscle weakness, which is mainly corresponding to the proximal muscle weakness. Can you all see this? There is a proximal muscle weakness with a very, very characteristic cutaneous lesion Both these favors the diagnosis of dermatomyositis. In dermatomyositis, we have a very characteristic proximal muscle weakness, which is because of inflammatory myositis. The cutaneous lesions are more specific here. You have thickening over the knuckles, which is known as Gottron's papule and plaque. Then you have a very characteristic rash, which is known as heliotrope rash around the eyes, the erythema and swelling of that area. You have confluent reticular erythema of upper back, which is known as shawl sign. They can also have ragged cuticle. Something is known as Holster sign, which is very similar to that of shawl sign, but on the lateral part of the thigh. Holster sign. So very characteristic of dermatomyositis. What is the answer here? Very nice. A 70-year-old female presented with pruritic eruptions on her lower abdomen, thigh since 10 days. On examination, there are 10 bullae on erythematous base. Oral erosions and Nikolsky sign is negative. Biopsy reveals subependymal blisters with inflammatory infiltrate of eosinophils and neutrophils. What is the most likely diagnosis? What is the most likely diagnosis? Now, let us mark the important points here. One is elderly patient with lesions or bulla which are tense. Now, these bullas have itching over it, and when you examine it, you can see that there is a lot of inflammation which consists of neutrophils and eosinophils. These are some of the points which give you an idea that you are dealing with a patient of bullous pemphigoid, where the defect is subepidermal. Next question. Am I audible to all my students? Am I audible? Am I audible to everyone? Nice. What is the correct answer for this? Six-year-old boy with Down syndrome presented with large warty crust on the hand, severe fissuring and scaling of the skin present on the buttock. What is the possible diagnosis? Oral erosions are absent. See, oral erosions and Nikolsky sign is negative. Okay. Oral erosions are negative sign. The Nikolsky sign is negative. That is what is given in the question. Clear for us? Now this is a question with the answer Norwegian scabies. If you remember, day before yesterday we have discussed, or I think yesterday we have discussed that Norwegian scabies usually occurs in a patient with a mental disease. In these individuals, the sense of itching is lost. When there is no sense of itching, the scabies tend to proliferate in such a way that it forms a very crusted form of scabies, which is known as Norwegian, also known as crusted scabies. Next question on your screen. 52-year-old female was admitted to dermatology ward with pruritic erythematous migratory plaque showing vesicles and crusting at the periphery in the intertriginous areas that becomes widespread. Stomatitis weight loss was also seen, and investigations reveal anemia, raised glucagon, blood sugar levels and pancreatic tumor. Identify this question. Identify this disorder. What is this disorder? What is the answer here? Anyone can tell me the answer? A very simple question. Now something which is giving clue in this particular question is the last line. Presence of raised glucagon and a indication of pancreatic tumor. This is giving you an idea that you are dealing with glucagonoma, and in glucagonoma you have a paraneoplastic syndrome which is known as necrolytic migratory erythema. This is a paraneoplastic condition. Paraneoplastic condition associated with glucagonoma. Is that clear? Rohit, Jyoti, John, Harshit. Necrobiosis lipoidica diabeticorum is a feature associated with diabetes mellitus. In diabetes, you will not see pancreatic tumor, while glucagonoma is pancreatic islet cell tumor, which presents with raised glucagon or glucagon and blood sugar levels. Very classical. Please remember the paraneoplastic syndrome is necrolytic migratory edema. Another question. What is the answer here? 10-month-old infant presented with fever, skin tenderness, erythematous skin lesions, blistering, crusting, especially in the perioral region and in the skin fold. What will be your diagnosis? What will be your diagnosis? 10-month-old infant presented with fever, skin tenderness. What will be your diagnosis? Very nice. Now in this question, the patient has tenderness of the skin which started after the ear infection, and following this there is blistering and erosions. This is a very classical description of staphylococcal scalded skin syndrome, where staphylococcus releases a exfoliative toxin. It releases an exfoliative toxin which goes and inhibit desmoglein 1, causing exfoliation of the skin. I hope this is clear. Anjali, Harshit, Kirti, John. A 15-year-old male presented to you with complaints of multiple red firm papules over his face, mainly around the nose, near the mouth. Further examination reveals lanceolate hypopigmented macules over the trunk. The most appropriate diagnostic test would be. Anyone? Which of the following is the most appropriate diagnostic test? And what is the diagnosis? Not the diagnostic test, but which is the most appropriate diagnosis here? Now this is a patient with some lesions on the face and hypopigmented lesions on the trunk. Yes, it is a diagnosis of tuberous sclerosis, which is also known as Bonneville disease. Tuberous sclerosis, which is known as Bonneville disease. Now it has a very special triad which is known as Vogel's triad, which presents with a very special triad which is known as Vogel's triad. It presents with epilepsy, loss of intelligence, and adenoma sebaceum, and this is very, very popularly known as epiloia. EPILOIA, epiloia. So epilepsy, loss of intelligence and adenoma sebaceum is the answer. Clear? The other cutaneous lesion is, you have what is known as ash leaf spot. These are nothing but lanceolate or oval shaped hypopigmented lesions on the trunk. They have hematomatous growth on the lumbosacral region known as Chagrine patch, and they have some hematomatous tumor on the nail fold which is known as Conant's tumor. which is known as Conant's tumor. Is it clear to all of you? Anjali, Rajashekar, Kirti, Mitran, Jyoti, Harshita. The next question is here on your screen. A 2-month-old male child with severe itching, irritability, generalized erythematous papule, few pustules, vesicles involving palm and sole, history of intense nocturnal itching with web space involvement was present in the mother, elder brother as well. What is the correct statement? Can you tell me what is the diagnosis here? Scabies. In scabies, the 5% permethrin is a treatment of choice. Topical sulfur cannot be used in infant. Please remember, this is wrong. Topical sulfur can be used in the infant. Oral ivermectin is not based on the sodium channel. It is the permethrin which is based on sodium channel. Ivermectin depends upon the GABA-gated chloride channels. While topical lindane can be used safely in children and pregnant female, please remember that topical lindane can be used or cannot be used safely. It enters or crosses the blood-brain barrier and causes severe effect on the patient. Next question. A 9-year-old girl presents with appearance of multiple vesicles which enlarges to form a flaccid bulla which has a purulent content. When they rupture, they leave behind a brown crust. What is your diagnosis? What is your diagnosis? Very nice, all of you. The correct answer of this question is option number 4. Whenever you see a turbid bulla, that is a bulla with a purulent content which is healing with a brownish crust or a honey colored crust, this becomes a very classical feature of bullous impetigo or non-bullous impetigo. And please remember, the correct answer becomes option number 4. 25-year-old man presents with recurrent episodes of flexural eczema, contact urticaria, recurrent skin infection and severe abdominal cramp. Diarrhea upon taking the seafood he is suffering from. What is the correct answer here in these individuals? John, Moshin, Kriti, Harshita. A 25-year-old man with recurrent episodes of flexural eczema, contact urticaria, recurrent skin infection and severe abdominal cramp, diarrhea upon taking seafood he is suffering from. Please remember, the correct answer of this question is atopic dermatitis. Presence of flexural eczema and recurrent skin infection and an allergy to seafood all give you an indication that you are dealing with a patient of atopic dermatitis. And please remember, in atopic dermatitis, the diagnosis is always clinical. You should have presence of itching plus 2 major or 3 minor criteria. In this, we are having 1 major criteria here, and there is 1, 2, 3 and 4 minor criteria. So this is a very classical example of atopic dermatitis. Moving to the next question, please tell me the correct answer here. What is the correct answer in these individuals? Please tell me the answer. A 36-year-old male from Bihar comes with complaints of hyperpigmented macule over the trunk and face. The nerves and the sensations are tested to be normal. No scaling is visible in the lesion. The patient gives a history of prolonged fever 2 years back for which he was treated. What is the drug of choice for this particular condition? Anyone? What is the drug of choice for this particular patient's condition? What is the drug of choice for this particular patient's condition? What is this diagnosis? This is a patient with post-Kala Azar dermal leishmaniasis. It's a patient with post-Kala Azar dermal leishmaniasis where you have a prolonged fever which he was treating or which he was treated for, but now suddenly started developing few lesions which are having normal sensation. So this is a patient with PKDL, and please remember the drug of choice in PKDL is miltefosine. It is not sodium stibogluconate because the oral miltefosine, which is easy to deliver with lesser side effect, and that is why you consider this drug to be the drug of choice. Sodium stibogluconate is a systemic drug. You need to do a lot of tests. There are transfusion related reactions and it is very difficult for us to give it to all the patients, and that is why miltefosine is considered to be a good drug. Next, 22-year-old female farmer with history of trauma on the left foot while walking barefoot. He has presented with the development of warty growth over the left foot. On doing the biopsy, brown colored lesions were found. What is the diagnosis? This is a recent NEET PG 2022 and INICT 2022 question. So already this was asked in 2 exams. So what this could be? What else you should think of in this patient? Anyone? Very nice. A patient with a warty growth and a very characteristic brown color bodies means copper penny bodies or medullary bodies or sclerotic bodies. They are the feature of chromoblastomycosis, which is a deep fungal infection or subcutaneous fungus. And the causative agent here is Phyalophora species. Okay, the causative agent here is Phyalophora species. What will be the answer for this question? Patient developed bulla without erythema on the elbow, knee and sacral areas, followed by crusting, scarring and melia. He had no photosensitivity and has a negative family history. The DIF was negative with no blood vessel involvement seen. What is the diagnosis? Anyone? Anyone can tell me the correct answer? A patient who have developed bulla, which is mainly present on the extensor aspect. These bullas have healed with crust and scar. Negative DIF, it means we are dealing with a very characteristic mechanobullous disorder, which is EB dystrophica, where collagen 7 is affected. It is not bullous pemphigoid because in bullous pemphigoid you will see no scarring. And the common site for bullous pemphigoid is periumbilical region or the proximal thigh or the proximal lower limb. But the site here is the extensors, elbow, knee as well as sacral areas. So the answer becomes option number 1. An 18-year-old boy from village presented to dermatology OPD with a well-defined annular lesions over the buttock, central scarring that is gradually progressing over the last 8 months. He gives a history of similar complaint in one of his friend. On asking further, he gave a history of open air defecation. So this patient used to defecate it in the open air. So there is a good possibility that there is a trauma on the buttock and following which there is an entry of a very important organism. Can you tell me what can be the answer here? What can be the answer in this patient? Very nice. It's a very characteristic description of lupus vulgaris, which is cutaneous leishmania, which is cutaneous tuberculosis. And I think by now you all remember that annular lesion with scarring in the center is cutaneous TB. Next. Ten-year-old boy with painful bogey swelling of the scalp, multiple sinuses with purulent discharge, easily pluckability of hair, lymph node enlarged in the occipital region. Which of the following would be the most helpful for diagnostic evaluation? Very nice, all of you. The correct answer for this particular question is option number 2, because the diagnosis here is tinea capitis. The diagnosis here is tinea capitis. Very important. The diagnosis here is tinea capitis. Clear? A 10-year-old boy with a painful bogey swelling of the scalp, multiple sinuses with purulent discharge, and easily pluckability of hair. Tinea capitis, what variety? Inflammatory variety, which is known as Kerion. Next question. We have done a very similar question in the beginning of the session today. Bogey swelling means soft. It is not hard. When you press it, you can simply cause a pit inside it. So bogey swelling, not a very hard swelling. Understood, John? And in this question, you have patient with periorbital puffing or swelling, the plaque on the dorsolateral aspect, ragged cuticle. All this points towards the diagnosis of dermatomyositis. But because the muscle weakness is not there, this is a variant which is known as amyopathic dermatomyositis. It is known as amyopathic dermatomyositis. Next question. Amyopathic dermatomyositis is the name given to it. Amyopathic dermatomyositis. What will be the answer here? Anyone? A child developing or develops non-blanching macules, papules on the lower extremities. There is abdominal pain. Skin biopsy shows IgA deposition, and we have perivascular infiltrate. Which is the most probable diagnosis? The correct answer of this question is Henoch-Schönlein purpura. HSP, which is a small vessel vasculitis, where you have immune complex mediated damage, and we have mainly IgA type of autoantibodies directed against the small vessels. 40-year farmer with itching, blistering on the sun exposed areas, complains of exacerbation in the summers. What is the diagnosis? "40-year-old farmer with itching and blistering on the exposed part." What is the correct answer? Please remember, the correct answer of this question is Porphyria cutanea tarda. PCT, it is a porphyria. When these individuals are exposed to the sunlight, they develop a very classical blister. They develop a very classical blister on the skin. Is that clear? Mainly on the sun exposed areas, they develop these lesions. What is the correct answer in these individuals? Anyone? Patient comes into the clinic with unilateral bluish brown speckled patch involving her malar face. Biopsy shows increased number of elongated dendritic melanocyte throughout. What is the answer? Nice. The correct answer of this question is nevus of Ota. Now, unilateral bluish brown speckled pigmentation presents on the face. Unilaterally, if they are present on the face with a normal collagen pattern, it's a very characteristic feature of what? It is a very characteristic feature of nevus of Ota, which is present on the distribution of trigeminal nerve. Clear? While if it is present on the back, it is known as nevus of E2. A sexually active male develop a vesiculobulous lesion on the glands after taking tablet paracetamol. What is the answer? What is the answer to this question? A 27-year-old sexually active male developed vesiculobulous lesion on the glands soon after taking paracetamol. The correct answer is it's a patient with fixed drug eruption. Now, whenever these lesions are healed, they leave behind a hyperpigmentation. And if a patient takes the same drug for the second time, he develops the lesion on the fixed site. And that is why the name given to it, that is fixed drug eruption. Next question. 45-year-old alcoholic male presented with erythematous to hyperpigmented scaly plaque over bilateral hands and feet of 3-week duration. There was clear demarcations between the involved and the uninvolved skin. What is the likely diagnosis? What is the likely diagnosis? Yes, FDE always heals with hyperpigmentation because there is damage to stratum basale. When the stratum basale gets damaged, the pigment falls down in the dermis and that pigmentation is very difficult to improve or heal. So it remains with a typical type of pigmentation. Clear? The answer here is pellagra because the lesions in an alcoholic patient are mainly present on exposed part and it is well demarcated. The normal and the abnormal skin is well demarcated. What is the answer for this question? What is the correct answer for this question, anyone? What is the correct answer? Very nice. A 55-year-old male with itchy lichenified hyperpigmented plaque on the forehead, cheek, nose, V area of the neck, that is the exposed part. They are describing that the lesions are mainly present on the exposed part. It is not present on the fold and you have a history of photosensitivity. Please remember this is a patient with either photodermatitis or actinic dermatitis because both of them is same. Now the correct answer is chronic actinic dermatitis because you have lichenification, which is a very characteristic feature of chronic actinic dermatosis. So option number 4 becomes the correct answer in this question. Before solving that, I want all of you to please solve this question. We have only 5 minutes left. A 45-year-old sportsman who noticed a small nodule over the upper lip for 4 months. The nodules are pearly white with necrosis and telangiectasia. The most likely diagnosis is. What is the most likely diagnosis? What is the most likely diagnosis? A 45-year-old sportsman has noticed a small nodule over the upper lip for 4 months. The nodule is pearly white with central necrosis and telangiectasia. The most likely diagnosis here is basal cell carcinoma. You can even get the image, and you can get an image-based question for this. 30-year-old patient with depigmented patch on the medial aspect of both the foot with feathery margin. The rest of the physical examination is normal. Which of the following drug should not be used in the treatment of this patient? Very nice. This is a patient with vitiligo, depigmented patches with feathery margins like this. This is a very classical lesion of vitiligo. In vitiligo, the main problem is autoimmune T lymphocyte damage to melanocyte. Autoimmune T lymphocyte damage to melanocyte. So for treating this condition, you need to give immunosuppressive drug. And all of them are immunosuppressive, that is topical steroids, topical calcineurin inhibitors, topical psoralins, but retinoid, which is a keratolytic drug, is of no use in these individuals. Clear? So the correct answer is option number 2. Next question. Very nice. A 2-year-old male who is born out of non-consanguineous marriage presented with recurrent infection. On examining the patient, we can see that the hairs are grey, but the skin and eyes are normal. So there is only depigmentation of the hair with skin and eye is normal. It's a very classical description of Griscelli syndrome. Very classical description of Griscelli syndrome. Clear? Very classical description of Griscelli syndrome. Next question. This is the next question. I think this will be the last second question or last question. A 30-year-old male patient comes with history of skin peeling, mucosal erosions for the past 3 days. On examination, 50% of the body surface area was involved with hemorrhagic cheilitis and crust formation. What is the diagnosis and the most probable underlying etiology in this man? Please remember, a patient with skin peeling, involvement of the mucosa, which is more than 50%, the exact diagnosis here would be toxic epidermal necrolysis, and this is mainly because of drugs. Toxic epidermal necrolysis, which is mainly because of drugs. Next question. Last question. A patient with history of recurrent oral ulcers with a very characteristic yellow floor surrounded by erythema. This is the description of Ephthus ulcer. So a patient with Ephthus ulcer and multiple tender nodules on the shin, which is a description of erythema nodosum. It's a very characteristic description of Behçet's disease. So the correct answer for this question is Behçet's disease. With this, we are done with today's session. I hope everyone have enjoyed this class. It was a long 1 hour session where we have discussed important MCQs. I request all of you to please subscribe Unacademy using my code CHESTA10. You can also subscribe this YouTube channel, which is a free channel where you can get all the subjects, free videos for the preparation of NEET PG exam or FMGE exam or INICET. Please hit the bell icon so that you get the notification of my classes. And please don't forget to give me a thumbs up if you like this class. Thank you all of you. Good day.